Good afternoon and welcome to the Penn State College of Medicine COVID-19 ECHO series for skilled nursing facilities. We're delighted to have you join us for this session. My name is Jackie Sable. I'm a member of the ECHO team and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you're speaking. If you're dialing in from a phone, you can use *6 to mute and unmute, or you can use the microphone icon on the bottom left-hand corner of your Zoom screen. You can also use the chat for communication purposes. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible. But if there are any unanswered questions afterwards, we always follow up in an email. If you have suggestions for future topics, please share via the chat tool or email us at echo@psu.edu. Please remember that no personally identifiable information is allowed when discussing patients. We are recording these sessions and we share all materials and recordings after the session. In the spirit of all teach, all learn, we will be on a first name basis during the session. For those who are not familiar with ECHO, our sessions will always begin with a brief lecture and are followed by either a case discussion or a question and answer period. Cases could include a question or challenge that you would want to address, and they're a critical component of the ECHO model. So we encourage you to submit cases that could be related to patients' preparedness policy or any challenge where you would like to generate discussion and ideas. The link to submit cases is always in our follow-up emails. Today's session will include a brief lecture on managing transitions to skilled nursing facilities by Drs. Ayesha, Ahmad, and Dr. Nicole, Osevala, followed by a question and answer period. During the lecture, please feel free to put your questions into the chat. We have a team of specialists online and they help to field questions, but remember this is all teach, all learn, so everyone can post both questions and answers. And again, after the lecture, we'll make sure to address all of the questions that do come in. And with that, I'm going to turn things over to Ayesha for our brief lecture.
Hello, everyone. Nice to see that there are about 35 participants on. So nice to have you, and thank you to the ECHO team for giving me and Dr. Osevala this wonderful opportunity. So I'm trying to see if I can, yes, thank you. So our topic is transitions of care, and I think for transitions of care to skilled nursing facility, it's always been a topic that's loaded with issues, and now in this COVID crisis, it's become even more of a hot topic. So just to give everyone a background, COVID-19 is a coronavirus, and it's a novel virus that started in Wuhan, China in December 2019, and by March 13th, it had become a worldwide epidemic, pandemic. As of yesterday, there were more than 640,000 cases in the USA, and more than 26,000 cases in Pennsylvania, which I believe is the #6 hardest state in hardest hit state in USA. We all know that our patients in long-term care settings are extremely vulnerable because of their age and their comorbidities. And there are numerous resources from CDC and the Pennsylvania Department of Health to kind of guide us through this difficult time. One thing you'll notice when you look at the stats is that out of all COVID patients that are hospitalized, 51% of them happen to be over 65. I'll also share, this may not be an official number, that as of yesterday, there were 297 long-term care facilities affected across Pennsylvania, and I think they were reporting 3,316 cases. So back to the topic, transitions across healthcare systems. I think everyone is feeling conflicted because we want to protect our vulnerable older adults in post-acute care and long-term care settings. But obviously, our overburdened hospitals also need to decompress. Staffing in post-acute and long-term care settings is an issue even on a good day. And with this crisis, it's becoming even more of an issue. Some long-term care facilities are facing serious PPE shortages. We all know that there are no negative pressure rooms in a nursing home. So, there are lots of guidance on cohorting, but the circumstances are almost never as ideal as a hospital. So before I start the conversation about accepting a positive or a negative patient, I think it would be nice to revisit the CDC guideline on when to discontinue isolation for patients. Ideally, you should be seeing patients on the test-based strategy because patients in the hospital that are coming to our facilities are priority one for being tested. Perhaps some of you are coming across non-test-based strategies too. But to go over these guidelines, if you're accepting a patient who was COVID positive in the hospital, you can discontinue isolation provided the patient is not running a fever without the help of antipyretics, does not have any significant respiratory symptoms or has a marked improvement in respiratory symptoms. And in addition, the patient has had 2 negative COVID-19 tests done 24 hours apart with a nasopharyngeal swab. That is ideal. There are also non-test-based strategies, which means that at least 3 days have passed since recovery, which is no fever, no significant respiratory symptoms, and at least 7 days have passed since the first symptom appeared. If you actually look at viral shedding, you come up with a lot of different variables. I will not, change the trajectory of the discussion, but maybe leave that to a question at the end. So, American Healthcare Association and the National Center for Assisted Living have come up with criteria in accepting hospital admissions. I apologize that the slide is kind of busy, but I wanted to project it as it is directly from their resource. Cohorting is a huge challenge, and I know Dr. Osevala is going to spend a little extra time talking about cohorting at the end and also address the new health systems alert that just came out 2 days ago. So at this point, at least in Pennsylvania and most of our counties, you should assume that COVID is all around us. And you're either accepting a patient that is negative or positive, and maybe some of us are accepting patients whose status is unknown. So if your patient is negative, at minimum, your facility, whether it's a skilled nursing facility or assisted living, should ensure that they are able to do vital signs per shift on that patient, that they are able to limit contact of that patient with other patients, that they're able to streamline the contact of various staff with that particular patient, and make sure that the staff is designated to this patient cohort rather than everyone else on your facility. So you should be doing at least number 1, number 4, number 5, and then number 6 if possible, which is cohort them either with the negatives or with the positives as stated later. If you're accepting a COVID positive patient, first of all, you need to make sure that your facility has a separate wing, unit, or floor to accept these COVID positive patients. The last thing you want is for them to be mingling with your COVID negative patients. You should be checking vital signs on them and monitoring them for fever and respiratory symptoms every shift. You should have all of your COVID positive patients in contact as well as airborne isolation. You should be making sure that you limit their contact with other residents, you limit their contact with staff and have a designated set of staff for your COVID positive patients. And if cohorting is absolutely not possible, then you may want to put your COVID positive patient either in a single room or with someone else who is also COVID positive. Then in the middle is a category of patients, sorry, I didn't finish for that slide, who is, whose status is unknown or asymptomatic. You should pretty much treat them like the positive patients, except the isolation, right? You should make sure that they're cohorted differently than the pure positives and the pure negatives. I don't want to talk too much about cohorting because I know Dr. Osevala is going to go over that too. So I thought that the AHCA and the NCAL guidelines were pretty helpful and perhaps a little bit more detailed than the CDC guidelines, which are next. So the CDC basically also addresses 3 patient-based scenarios. You're either accepting patients for whom transmission-based precautions are still requested, and if so, you must make sure that your facility has adequate personal protection equipment, can cohort them, and preferably a facility that has already cared for a COVID positive patient. If you're taking patients from the hospital for whom transmission-based precautions have been discontinued, you should still make sure that you restrict them to their room and give them a single room. That would be ideal. And for patients for whom transmission-based precautions have been discontinued, may not require a lot of extra restrictions. However, each facility may decide to take some added precautions.
So I'm going to just speak briefly about what we came up with at Penn State. One of the challenges I will just mention with the guidelines that are coming out is they don't offer a time frame. They offer a test-based and non-test-based strategy regarding precautions, but they don't really comment on how long they should be in place, other than we either have to be very comfortable and confident that 2 negative tests mean the patient is no longer infectious, or we have to accept that 7 days after onset of symptoms, if the symptoms are resolved, that they're no longer infectious. And I think we all fear in our elderly population that that may not be 100% reliable, and we're bringing people into a very high risk situation where we could expose residents who would otherwise not be exposed. And so that really made us stop, look at what the guidance is, and then think through how can we make as certain as possible that we're not exposing the existing residents, especially in a COVID naive facility, to this disease, but also recognize that in our community and in our hospitals, we need to think through, if we have the capability to bring these patients in, how we can do that in the most safe manner. So the first piece I will recommend is the facility transfer form. So we request that the hospital completes this hospital to post-acute facility transfer form, and this gives our site a very good idea about if the person coming in, there was concern for COVID or not, if there was testing done, and what the status is. Some of the EMRs automatically populate in a way that it can be misleading. The information may be incomplete. And so this form is really helpful in getting the most up-to-date information regarding if your patient was tested and what the outcome was. For us, we have not really looked at the test-based strategy and giving us any extra comfort, nor changing what we would do to handle a patient coming from the hospital with or without COVID. Our comfort level is still in that we would prefer to keep them isolated with precautions for 14 days, particularly if there's community spread. So in the first bullet, patients symptom-free for 3 days. What I've learned from our hospitalists is many of these patients are still coughing. Many of them are still hypoxic, requiring some supplemental oxygen. And some of them still have fevers, but they're medically stable. So if you have a crowded hospital and the patient's stabilized and they're past that kind of peak time where they can either recover or get sicker, and they're looking to bring them out, those might be criteria that you have to reconsider. And that's why even the time-based strategy for discharge has its flaws. For us, the main concern coming out is the airborne isolation, as Dr. Ahmad alluded to. We don't have negative pressure rooms in these nursing homes. So, you know, in our case, nebulizers as well as the CPAP and BiPAP are the primary concern. And that might be the only instance where we really want that, the 2 negative tests to know that we're not going to aerosolize virus. And otherwise, a patient that would be, could have a roommate if the roommate was COVID positive. I think might be missing part of this slide. There we go. The other piece is that in terms of the length of time, so a lot of us are seeing 14 days of quarantine after leaving the hospital. We know that viral shedding actually might be more prominent before the symptomatic phase. So within the first couple of days before patients are symptomatic is when the viral shedding seems to be the highest. And it seems to decline, but again, in our elderly population where we're immune compromised, you know, we can't be for certain that there might be lower levels of viral shedding or environmental contamination of the patient themselves. And so what we're recommending is that for 21 days out from the time of their diagnosis, they remain on droplet and contact precautions, that they are admitted to a designated COVID unit wing or an area on the unit where the door can remain closed, and that you have designated staff. If they're out from 21 days at that point, and they can come off of their precautions, come out of the unit, but they still need to adhere to wearing the mask if they're going to come out of their room.
So I'll briefly walk you through a real case. So let's assume that you're covering post-acute care, long-term care service in a large skilled nursing facility in central PA. The admissions team just calls you that they've accepted a return. This patient was a long-term in your facility. He was sent out to the hospital last week for a low hemoglobin of 5.8 because an emergent transfusion could not be arranged. He is an 82-year-old male with a history of heart failure, clinically compensated, chronic kidney disease, COPD, and has had issues with chronic GI bleeding from AVMs that are kind of all over his cecum and his small bowel, for which nothing can be done except localized cautery and other procedures which have not worked. So almost every few weeks he requires a transfusion. However, to complicate matters, one day before this happened, he had run a fever. So he was tested for COVID and he was sent out to the hospital with results pending. The results came back as positive while he was in the hospital. So he was placed in isolation. He did not need any COVID treatment per se. He did need several transfusions. He fortunately did not have a lot of respiratory issues despite his comorbidities, which is kind of miraculous. And he's now returning to your facility. He tested positive approximately 6 days ago. So obviously, if you are a COVID-19 naive facility, you know, you may be in a state of panic. If you are a COVID positive facility, your panic levels may be a bit lower. And I think a lot of questions come to mind. For example, what else do you want to know about the patient in terms of their respiratory symptoms? Is your facility prepped? Do you have a separate wing or a unit? Will he be coming back to the same unit? If so, is that safe to do? Can you decline a patient, which in this case would be very challenging because he was your patient. So I don't know how you would be able to decline this patient. So I think so many questions come to mind when you actually are requested to accept a positive patient from the hospital, which I'm sure is happening to many, many facilities across the state. So I'll let Nikki tackle the remaining slides, and then obviously if there are questions regarding this real case or any of the other aspects of the presentation, we'll try to answer them after she's done with her slides.
Oh, now I'm unmuted. Sorry. So just to briefly comment on the patient, having them keep him there until he tests negative may not be in his best interest, particularly if he's stable. And so the test-based strategy is not necessarily going to inform how you handle him coming out. So I think there are challenges to strictly requesting test-based strategy to determine if someone is infectious or not. He's still early on in his course, and so you are going to want to bring him in and think about cohorting. So the PA Health Action Network put out some guidance on cohorting, which I think can be applied to both cases that happen kind of from the ground up in the facility, but also if you are in a position where you can cohort and accept these patients. And their statement is that if you have a dedicated unit, it can be an effective transmission prevention strategy to group these patients and keep them on the unit, with the primary goal being that you're restricting the mixing of cases that are positive or patients who are likely to have been exposed with those who are highly unlikely to have been exposed. And then the secondary goal being separating cases from exposed cases, exposed residents. So if you have a roommate, they're highly likely to be exposed. And so that may not be a primary goal, but it may be something to consider depending on if you're able to cohort. And so they group these into three types of residents, whether it's a confirmed or probable COVID case, an exposed resident, or someone who's not been known to exposed to COVID. And when we think about this, we have to think about what the benefit is and where there is limited benefit. So if you have a designated COVID unit, and you know all of the cases can be safely contained within that unit, you will have all of your staff in full PPE, which would include contact and droplet precautions, gown, gloves, surgical mask, face shield. We can talk about N95s, which are typically used for airborne precautions, which these residents should not require unless they're receiving aerosolizing procedures like intubation, suctioning, BiPAP, or nebulizers. You can have a designated unit for monitoring new admissions. So if you're big enough that you can take any patient coming in from the hospital in that middle category Dr. Ahmad alluded to, which is the unknown status, which many sites where we have widespread COVID in the community are concerned about taking any hospitalized patient with or without COVID testing. You can consider cohorting them in that way so that they stay on that unit for the first 14 days. And again, your staff would be in full PPE in that circumstance. And then if you're in a situation where you have the first COVID positive resident in a unit where you don't have any other residents that have symptoms, you may want to move that person to an isolated area to prevent the spread of COVID across the unit. Where there is not found to be benefit is if you have a COVID positive patient in a unit where there are others already experiencing symptoms, or several patients that turn positive within a few days. In that case, sadly, you have to assume the entire unit has been exposed and staff wear full PPE, and you manage as such. So the next thing to think about is if you have preparedness in place. And so if you have COVID in your facility, or if you are in a community where you have sustained you know, you want your healthcare providers in those situations to have full PPE for residents patients coming in from the hospital on a designated unit or across the facility if you have COVID present across the facility. You want to think about how you can implement protocols for extended use of eye protection and face masks in particular. And of course, at the very minimum, all of your healthcare providers should be wearing face masks in the facility and have exquisite hand washing in between patient care. For the residents, encouraging them to remain in their room, which can be very difficult, particularly on dementia units, or in sites where the residents are accustomed to being able to come out and interact with one another. Really, the education for the residents who are able to understand can be very helpful. And if they are to leave their room, they should wear a face mask, and then you should also educate them on proper hand hygiene, limiting where they go, preferably staying on that unit, and maintaining social distancing if they do come out of their room with a mask on. And then other things to think about to minimize the contact with these residents. So, you know, even with full PPE, the movement in and out and the time you are in with these residents can be very important. So thinking about bundling patient care so your staff member isn't in and out of these rooms. Having designated staff and physicians for the COVID-19 confirmed residents. Discontinuing therapy services, again, limiting the number of people interacting with COVID positive cases, stopping unnecessary medications that can reduce the time as well as the frequency of med passes, avoiding aerosolizing generating procedures, particularly nebulizers, as well as BiPAP, and thinking about how you can implement telemedicine, particularly providers using it to do routine follow-ups and perhaps even the intermittent check-ins that you may want to do throughout the day with your COVID positive residents. And then lastly, I think this is something that has to be stated. I know in other states there have been mandates that nursing homes must take COVID positive residents and patients from the hospitals. The simple truth is we've seen this in the press, we've seen it within our own communities. It spreads very quickly in these sites. And if you ask a nursing home that does not have the ability to cohort, that does not have the proper ability to manage the PPE, we are putting residents at risk. And so the Society for Post-Acute and Long-Term Care Medicine has put out a statement that their feeling is that nursing homes should not be required to admit COVID patients. With support, nursing homes may be able to cohort in wings, floors, or entire buildings. And this is something that those of us who work in long-term care should work towards so that we have that capability. They also state that incentivizing and collaborating planning with not only nursing homes, but hospitals, public health and emergency management authorities within states can be helpful as well. And we are not there yet in Pennsylvania. But this is where some of the larger health systems that have nursing homes in their community where there is a need should look at how they can collaborate, particularly with PPE and staffing. And then lastly, they make a statement regarding the creation of alternate care sites through federal funds. That concludes our presentation, and we're happy to take questions.
Thank you for that. Juliet, it looks like you were typing a question, or we have an R there. So if you want, thank you.
And actually, I can verbally ask the question.
Please do so.
Actually, my mother's in a skilled nursing facility, so this topic is very close to me. I've asked questions of the nursing staff whether they've got policies in place for how they will communicate with family members if there is either a COVID positive resident there or a healthcare provider. I was told that the only way they will notify families is if they know there was direct contact. Is that really the proper guidance? What if it was a kitchen worker or anyone else? What is the best practice related to that right now?
Right, so you're correct. There are no requirements for nursing homes to report to patients who are not directly affected by COVID, the status of other residents in the home or the staff. That puts families in a very difficult position because you don't have situational awareness about what may be happening in the building. And there's already a sense of not having control because you can't visit your loved one. And some may have limited ability to communicate what's going on. And that just increases the tension between what's happening in the building and what family members are being told in real time. I don't know that I have an answer to how to resolve that other than to state that I do know that the Department of Health, I saw on their website, is now posting cases specifically within counties that are related to nursing homes. So we're getting a little closer to being able to at least count. I think this is something that our public health officials and policymakers really think about, because this is, even though your loved one may not be directly impacted in the moment, we know that there is increased risk once COVID is present in the building, that others are at higher risk of getting it. I don't know that that answers your question, but I wholeheartedly agree. It's a very difficult position for family to be in, to not know what the situation is in the building at any given time.
Thank you.
And I think these are uncharted waters for nursing homes as well as hospitals. So we're all learning through this.
Are there other questions related to either the lecture or the case that was shared?
I have a question for those listening. And is there anyone that feels strongly that a test-based strategy would change how you handle patients coming into your sites? I heard that on the call. There are over 600 people that dial into this this update line. And the question today was, you know, shouldn't we be requiring everyone to get tested before they leave the hospital going to a nursing home? And the more I'm reading, the more my sense is that we should handle everyone as though they could be asymptomatic at the very least. And so that doesn't necessarily change how we handle them when they come into the facility in terms of the isolation piece, the PPE, and with limited testing capabilities in this moment. So we're dealing with a not ideal scenario. You know, I wonder how hard we should push to have the test-based strategy when we would still want to treat those residents coming in as though they may have been exposed, even if they are not COVID positive. I don't know if anyone has a different argument for that.
So I currently work in a rural hospital in a PCU unit, and we have 2 COVID positive patients. One was on a ventilator and has gotten off, waiting to go to a nursing home. One came in from home needing to go to a nursing home because her family is also positive. We cannot get 2 negatives on these individuals, and the facilities are requiring 2 negatives, and they have been sitting with us for greater than a week now. They're doing fine symptom-wise, but we just can't get them cleared.
Mm-hmm. Yeah, and I think hence, you know, this is not going away. I think some facilities are handling this as though if they pick this battle for the next 2 or 3 weeks, that, you know, this argument will be behind them. But, you know, this is with us probably for another year. And it is not feasible to have these older adults sitting in hospitals, either awaiting tests or becoming COVID negative. On the other side, we don't want to expose residents that are in COVID naive facilities to this if they're not equipped to handle it. And so we need to think through how we are going to safely handle this. And so our mode has to be moved from we're going to just refuse them until they're negative to how do we prepare ourselves to protect all of the other residents in the building, and be able to bring them when they're medically safe. You know, that's been my takeaway. I don't think saying no will remain an option everywhere. There are some sites that I think will need to because they don't have the space or ability to properly cohort and protect other residents and staff. But in the sites that do, I think we have to move from a position of no to let's prepare ourselves and make best practices and handle this. So I definitely hear what you're saying, Lisa.
Hi, my name is Melissa. I just came off an ECHO meeting just locally here in Charlottesville, Virginia, and we actually just discussed this. So it's currently in the process of being arranged, but here locally we plan to help facilitate dispos from the hospital and into the skilled facilities is to have 2 negative COVID tests within 24 hours apart to facilitate those discharges from the hospital.
Do you know if those facilities will still keep those patients under isolation with full PPE?
I don't know at this time, but the PPE situation out here for those facilities is not very good either. So there's facilities that don't have adequate PPE, and we're trying to facilitate resources to them as well.
Mm-hmm.
Yeah. Hi, this is Chris Horn. I'm the Vice President of Operations for, I oversee 4 assisted living communities. I'm also the President of the Board of Directors for the Pennsylvania Assisted Living Association. And I think that some of the issues that we're experiencing are first of all, the PPE is a major factor, and I realize assisted living and personal care are not skilled nursing communities, but we are dealing with COVID patients throughout the state of Pennsylvania in several of our communities, both staff-based and resident-based. And because it is such a fragile population that we are working with, it's very important that if the hospital can't secure 2 negative tests prior to discharge, and we also, in my prior life to long-term care, I was the director of discharge planning at a hospital. So I get it. I get the fact that we need to transition patients out of the hospital to make room for those that are more critically ill. But we also want to understand who are we bringing into our communities. If, not, like you said, not every community is set up to be in long-term care, multiple floors, multiple units. And so isolation is very critical in how we're going to manage that, on top of not having enough PPE for our employees. And I know of communities that have basically had their residents without visitors since the beginning of March, and no resident has developed COVID. So we know that in those communities, the only way it's coming in the building is via a staff member. And to Juliet's point, I think that, wherever your mom is, I would guess that community is a member of Leading Age or PHCA, and they've given guidance to their communities on how to communicate with families. I think it's very important that we do communicate with families because they don't have situational awareness. So this is all a very fluid situation. Nobody in the long-term care arena, I don't think, was ever prepared for anything like this. And I don't really think that any of our hospitals were anticipating anything like this and how it would affect the long-term care arena. So it's all very fluid, but I think we have to just, I think the idea of developing these regional collaborative efforts with healthcare systems across the continuum is best, because obviously in the southeastern region of Pennsylvania, they're experiencing something much different than central Pennsylvania or even western Pennsylvania. And
Agreed.
that's all I'm gonna say.
Thank you for sharing that. We have some questions and comments in the chat that I'd like to get to. First, Janice shared that an expert panel of pharmacists developed new deep prescribing guidelines. She provided the link, it's in the chat. And then Dan responded to that and indicated he was peripherally involved on that, on the deep prescribing guidelines. And Dr. Westcott and he are interested in them, in that. So he said, feel free to call. I don't know if that was a general call, but he did put his email into the chat for all to see. And then there was a question that came in from Juliet. Do you want to go ahead and state that, or would you rather I just read it?
Sure. You know, there seems to be a real focus in hospitals and skilled nursing facilities with having staff check their temperature prior to starting their shift. And I guess I wonder if that's a false sense of security. I mean, we know that there are COVID positive patients that don't have a fever. Are there more than just temperature taking things going on, like questionnaires, et cetera? So I was just curious about the screening process of the staff before they start their shift.
I can take that. So yes, other than temperature, they also ask questions about other symptoms, where else you work, whether there's an outbreak in any of the other facilities where you work. So it's you know, not a very comprehensive questionnaire, but it does have several questions about the disease. And I agree. I think in the beginning, we didn't realize how asymptomatic patients could be passing this virus around. And that concern has grown bigger week by week. So wearing a mask to protect others from you is probably, you know, a very wise strategy. Yes, but they are taking temperatures as you enter and exit.
And Jackie, if I can say something, that's some part of the wellness program that we've put into 62 nursing homes up and down the East Coast, where, again, your body temperature in the morning is different to your body temperature in the evening. So everyone has to take their body temperature and actually know what their normal body temperature is over a week period. So so we've got that good baseline there. We started off with the low-grade fever sort of indicator was about 100 degrees Fahrenheit. Then we dropped it to 99.5. Now we're at 99. And if any staff member, and again, knowing what their baseline is, if we see a 1 to 1.5 degree increase, then we try to ensure that based on our wellness program in the day when they come to work, we do ask those questions. Do you have a scratchy throat, nasal congestion, headache, any fatigue, any muscle aches? That we go through a whole list. Then we keep them away from residents. And again, I totally agree that it's not a perfect situation, but the majority of patients, the majority of COVID patients that I've seen, they all have had a fever pretty early on. It might be a low-grade fever, but there's been an increase in body temperature. As long as you know what your own personal body temperature is, both in the morning and the evening, then we can see it goes up by, say, 1 to 1.5 degrees.
Thank you for sharing that, Gavin. So going back to the communication from the nursing homes, there are a couple of comments and strategies listed in the chat. So Dan pointed out that communication is extraordinarily important, but also exceptionally difficult and time consuming. But then Cindy said that they send out blast emails to the families with updates. So I don't know, Cindy, if you wanted to add to that, or if anyone else has experience with different types of communications. Go ahead, Dan.
Hey, thanks. Can you hear me?
Yes, we can.
Yes.
Okay. You know, I think the point you have to realize is just how hard this is on families because they've been out of the buildings for a month now. And what happens is they, especially in a place where you're having an outbreak, they'll call, the staff's too busy to talk to them. And I've had multiple examples where people call, they don't answer, and they say they're fine. Like I had one administrator, this is unbelievable, who told the family, ready, don't worry, which is the exact opposite of what you should be doing. So I think that, you know, as far as talking about code status and things like that, you need to talk to them. I think there's a different conversation between a healthcare professional and the staff, which is, you know, not that one's better than the other, it's just different. But I really think you know, the facility staff has to be proactive with that, maybe make a line list and have somebody call the family, like have a list that says, does the resident have cough, fever, symptoms, you know, because it presents unusually, and really go out of their way to call the family each and every day because they're as nervous as all get out and it's heartbreaking to watch. And I think we in the industry have to really take their concerns to heart and be exceptionally good with communication.
This is Chris Horn again. I work with Cindy, and in our communities, we have the administrator for each building develop a letter every week and give an update as to the status of their particular building and what's going on. And we do an email blast to all the families so they receive that. But we also have scheduled video chats, depending on the type of device that the families have. If you have an iPhone, you call in on a Tuesday. If you have an Android, you call in on a Thursday or whatever. And that each family has a time slot, and we take the phones back to their loved one. They see them, they talk to them. And we do that on a weekly basis as well. And we've had remarkable success with all of our families across all 4 buildings, being very grateful for the communication that we do offer to them. So anybody that's in the long-term care arena, if you'd like more information about that, I'd be happy to help you.
Chris, how big are your facilities?
Each of our communities is, 3 of our communities have 42 private apartments, and one of our community has 53 private apartments.
And then who is the recreational director kind of in charge of this, or?
No, this is the administrator, and the resident services director, which is equivalent to director of nursing, because I think it's very important right now that the families hear from the people in charge, and they need to know that the people in charge are confident in what they're doing, and they're confidently overseeing and supervising the direct caregivers that are providing that care.
That's great.
So Amy has a question. She's asking, I don't know, could someone comment on how we could network to direct resources, PPE staff to the homes who need it, just like we're doing with ventilators in hospitals. And she also asked about commenting on creating a network of COVID-19 positive and negative buildings. Would this be valuable to do?
Absolutely. I would defer to Dr. Osevala, who's working closely with the DOH.
Yeah, I mean, I think in some sense, because COVID is widespread right now, it's difficult to identify sites that are COVID negative and positive. In Massachusetts, they attempted to create nursing home strictly for COVID residents, and in the process of moving people out into what would be COVID-free nursing homes, residents turned positive, and so they had to abort that plan. And so while I think the concept makes a lot of sense, because we have such widespread transmission throughout the community, I think it would be difficult to create COVID negative and positive sites, because at any given time, a negative site could become positive. That being said, I think the concept of an alternate care setting, particularly when it is widespread in certain regions, like the southeastern part of Pennsylvania, may make a lot of sense to spare the sites that may be COVID naive or may not have the ability to properly cohort, which is really where I think we have to focus our attention. Is, there are some sites that, while it may be a burden, they can safely cohort and protect the rest of the building. There are sites where that's simply not possible. And so, those are the instances where those particular sites should have the ability to refer those residents to an alternate care site. And that's really something at the state level that needs to happen. Although I will say, I heard in the news fairly recently that LGH was looking at an alternate care site for residents who don't need hospital care, but aren't really well enough to go stay in a hotel per se on their own, that may need some level of assistance, but not medical care. And so some health systems are even having to take it upon themselves to think through what they can do. And it might be out of concern that the nursing homes where they would normally refer patients just are not comfortable accepting them right now.
And Jackie, if I can just add on that, one of the things we're doing in the nursing homes that I'm working in, even with the ones that have cases, we've created zones. We've got a copy of their floor plan, and we've created zones by using plastic sheeting shower curtains to identify those zones with tape on the ground. But also when we go to review the protocols, the cleaning and disinfection protocols at the nursing homes, the biggest red flag for me is no one's reading the label and following the directions on what the dwell or wet contact time is of the chemistry of the product to actually inactivate or kill this virus. And so we've had to go review that we're not here to do a clean and shine, we're actually doing a clean and disinfect to kill a virus. And that we've needed force multipliers for that. So we've actually needed to recruit more people because we didn't have enough cleaning staff to create the effort, the level of effort that was needed to decrease the viral load in these buildings.
That's a great point.
So thank you for those responses. Amy is just bringing questions one after another here. So this is while you're discussing transfers out of the hospital, thinking about trying to be mindful of all transfers. Is there a role for just-in-time palliative care telehealth visits prior to transferring to the hospital? And I might pick on Christy.
I was going to say, I see Christy there.
It's before people leave the hospital. Oh.
Prior to transferring.
Yeah, so there are a few different things happening within hospitals in terms of family visits and clinician visits. And so I can speak to, I'm from palliative care at Penn State, and I can speak to palliative care teams around the country are working to try to increase communication with patients and families from the hospital to home. I imagine, similar things to what were mentioned earlier about trying to communicate and keep families up to date using either phone or various video methods. We're also, in some hospitals we have like video ICU setups. And so some hospitals kind of already have some of those setups that are easy to use. There are also clinician visits that are being done through telehealth, both in the hospital and outside. And so there's palliative care teams across the country that are very small. And so they have one or two clinicians. They really can't risk one person getting infected. And so one of our hospitals just down the street in Dauphin County is doing all of their palliative care consults through televisits. through that kind of EICU mechanism. And so there are various things that are being done. And I don't know if that specifically answered the question that was asked or not. I can expand if needed.
So Amy, does that address your question? And I go ahead.
Took me a minute to get off mute, sorry. I was curious if transferring from the nursing home to the hospital, if there's been any success in doing telehealth just in time before they go to the hospital, because transfers both ways put a lot of providers at risk, the paramedics, everybody. And, you know, sometimes we've had great discussions in the home. However, it takes that expert person in palliative medicine to really help the family come to understand that maybe the hospital isn't the best place for their loved one with COVID.
I'm sorry, I wasn't understanding the question, but go ahead, Ayesha.
Oh, if I may add to my horror, for some of my COVID positive patients in the skilled nursing facility, when we reached out to family to reaffirm their goals of care, they've upgraded them from DNR, do not transfer, to full care, which is the opposite of what should be happening. So I'll let you, Christy, answer the question.
Yeah, I'm sorry, Amy, I wasn't understanding correctly. So there certainly are some opportunities for that to happen, and you have that expertise yourself. So I'm sure you've been thinking through kind of how that can be done. We've done some of those even in the emergency room. So most palliative care teams are not present in a hospital 24/7. And so some of these visits are being done telephonically or through telehealth. So I think there are some opportunities for that, and we've been collaborating with our primary care clinicians in the community as well to have some of those discussions and equip people with the kind of the language and the skills to be able to do that. We have seen some of those situations where, paradoxically, somebody who we know had a short prognosis, I think people get paralyzed by this, just the unknowns that come along with coronavirus, and we throw out kind of everything that we know about what happens to people who are older or people who have comorbidities, and then we kind of act as though we should treat coronavirus totally differently than what we know about other illness. And so we have seen that happen in a few settings. A couple of hospice patients came in and got intubated for treatment of their coronavirus. So we know that is happening somewhere, and there's opportunity for improvement. So if a palliative care telehealth visit isn't available in your specific community, I would refer folks to the Center to Advance Palliative Care to utilize some of the tools that they have available to kind of prep people to be able to have those conversations. But certainly that's something that we would want to promote, and we'd be available to try to do if that would be helpful in our community nursing homes.
And I'd like to make sure, I don't know if this was addressed or not, but Amy also asked about how we could network to direct resources like PPE and staff to the homes who need it, just like we do with ventilators in hospitals.
I can comment on that a little bit. So the original setup was that if nursing homes, assisted livings were in need of PPE, that they would submit a request if there was a critical need, for example. My understanding is the Department of Health has moved to a push system. So they're actually asking nursing homes to submit the COVID status, both of the residents and staff in their building. They're looking at the county, the size of the building, and what the capacity is. And I believe they're using that information to push PPE to the sites that need it most, rather than relying on the requests to come in. With that, there may be opportunity to swap. So one of the health systems on the call this afternoon said, we have an abundance of regular size N95s. We have a lot of people with small faces that need the small N95s. Does anyone have, want to swap and kind of brought up that idea of, you know, how do we take what we may have in excess resources in one site and share that and then make available to us what we actually need. So I think that concept has been brought up on a state level, and I think it does, you know, raise the idea of, you know, with such limited resources, how do we make sure that, you know, what any given site is in need of, if another site has it, you know, how can we provide that to support others in the community? So likewise, I will state some of the assisted livings that we've been calling in our telephone support program are concerned that materials will be taken away from them. You know, if they were able to get an adequate supply of PPE, that with the governor's announcement that, you know, they will redirect to where the sites need it the most, that nursing homes may be somehow at risk of having PPE taken away. And, you know, I've been told that's not the intention at all, and that, you know, nursing homes are actually of great concern. So they would not be looking at assisted living nursing homes to, you know, redirect PPE to other sites. So it's interesting to hear the conversations that are coming up, but I think Amy has the right idea. With so few resources, if we have excess of one that's not being used and another site, you know, happens to have something else, you know, can we pool that so that we make sure everybody has what they need?
So we are almost out of time. There is another comment question in the chat for those who cannot see it. Melissa indicated they're in the process of setting up telehealth in SNF with Outbreak to allow for communication. They have received a unit. I'm not going to get all of this out. Currently trying to figure out more logistics to facilitate. They also had medical individuals from the university hospital do on-site surveys. So it sounds like, Melissa, you have a lot of things going on. And if you'd like to add to that real quickly before we wrap up, feel free to unmute.
Is Melissa still here?
Sorry,
She is.
But then, yes, so, you know, it's just been a really critical situation, especially for just a very local facility that nearly every patient is positive. You know, 10 plus staff members are positive. Medical director was on quarantine, nursing director quit. And, you know, they just didn't have the staff. We were having staff all the way from Texas driving straight through to come support. So, you know, and this is also a facility that didn't have hand sanitizer 2 weeks ago before their first case. So we here as the local ECHO team are really trying to facilitate getting them supplies. We've been in contact with just local entities that are, you know, making supplies and that type of thing. There's a lot of logistics, and one of the individuals that are helping us, he is the EOC for the emergency response. So he's doing a lot of coordination as well, along with like United Way. You know, collectively, we're trying to do the best that we can. But yeah, it's not a good situation necessarily out here for these facilities.
Yeah, I'll just add to that. I think, you know, as we see the donations rolling into our frontline staff in the hospitals, which I think are, you know, certainly warranted, a community response to our nursing homes and assisted living personal care sites, I think, you know, hopefully our communities will start looking and recognizing that there's really great need there. And in some cases, they have even they have far less leverage to access resources. You know, even things like thermometers, we're having turn up as being something that they either can't afford or can't find to purchase to monitor their residents. So I think that's really a really great way to kind of round it out, and that the nursing homes and assisted living personal care homes need community support as well.
And just in relation to the title telehealth, that's one of the units that comes with the ability to listen to lung sounds, look in the throat, the ears, and it's very useful. However, we have to also understand that the 2 nurses that are taking care of 40 plus patients, and nearly every one of them is positive, and some of these individuals, you know, are from out of state just trying to support staff. They also don't have the time to be utilizing these devices and be our boots on the ground per se for us to be able to do this either. So we're really still just trying to figure out, like I said, all the logistics on how we're going to facilitate.
Well, I hate to stop a really good conversation going on, but we are 2 minutes over, something we don't do with ECHO. If you have any last minute questions, please put them into the chat. I would like to thank everyone who contributed today. I think we will be doing these specific sessions every week. We also have additional sessions coming up from our other COVID ECHO presenters. So please watch your email for the next sessions. We do have one tomorrow morning at 9 a.m. Doctors Emily Link and Laurie Nelson will discuss COVID-19 clinics. Remember, you can collect CMEs for today's session. And as mentioned earlier, all materials from today will be shared via email. Please consider submitting a case and we hope to see you again. Thank you, everyone.